Greetings from Flagstaff, Arizona. My name is Julie Baldwin, and I am one of the MPIs of the Institute for Translational Research Education in Adolescent Drug Abuse. I also direct the Center for Health Equity Research at Northern Arizona University. Over the last 27 years, my research has focused on working with American Indian populations to address substance abuse and other chronic health conditions. As an enrolled member of the Cherokee Nation of Oklahoma, I'm especially passionate about serving American Indian children, youth, and families. I hope that you'll find this presentation informative and that it gives you a glimpse into some of the most important issues related to behavioral health disparities among American Indian and Alaskan Native peoples and youth, and how we might begin to address these concerns. American Indian and Alaskan Native populations include people who maintain tribal affiliation or community attachment with the original populations of North, South, and Central America. Each tribal community has unique cultural teachings, traditions, and languages. In the United States, there are 567 federally recognized tribes, more than 100 state-recognized tribes, and some tribes that are neither state nor federally recognized. As of 2012, there was an estimated 5.2 million people, or 2% of the total U.S. population, classified as American Indian Alaskan Native alone, or American Indian Alaskan Native in combination with one or more other races. Approximately 25% of American Indians and Alaskan Natives live on reservations or other trust lands. Of the approximately 75% who live outside of tribal areas, 60% live in metropolitan areas. Rates of diseases and other adverse health outcomes are higher in American Indian and Alaskan Natives than in other communities in the U.S. American Indians and Alaskan Natives have higher rates of emphysema, chronic bronchitis, and asthma when compared to whites. Furthermore, American Indian and Alaskan Native men and women are twice as likely to be diagnosed with chronic liver disease. Among adults 18 years of age and older, American Indian and Alaskan Natives have the highest rates of heart disease and are 60% more likely to be obese than their white counterparts. Obesity rates among American Indian and Alaskan Native youths have increased to 30% of all children under 10 years of age and 48% of teenagers and young adults. The leading causes of death among American Indian and Alaskan Natives are heart disease, cancers, and unintentional injuries. Among American Indians, mortality rates due to unintentional injury is twice that of whites. Deaths due to diabetes and chronic liver disease and cirrhosis also occur at a higher rate than among other races. The high prevalence of a number of different chronic health conditions as well as behavioral health disorders in American Indian communities is believed to be linked to a number of historical and environmental factors, such as historical trauma, contemporary discrimination, current-day unemployment, academic failure, high-risk occupations, and lack of health insurance. Historical trauma, such as living in boarding schools, as shown in this picture, likely contributed to unresolved grief that led to mental health issues, self-destructive behavior, and other negative health outcomes. Distress and alienation from cultural traditions may also lead to or be associated with depression, learning problems, conduct disorders, substance abuse, running away, and suicide attempts. Historical loss is a current and ongoing consideration for many Indigenous youth. 25% of adolescents report daily thoughts about loss of their tribal lands. In another study by Soto et al., they found that historical trauma was a risk factor for commercial tobacco use, both directly and through several mediating factors, such as cultural activities and ethnic identity. The impact of substance abuse complicates the effects of historical trauma, often amplifying negative impacts and putting users at increased risk of experiencing or inflicting trauma. In terms of contemporary discrimination and trauma, this is a greater predictor of substance abuse than historical trauma. An early childhood exposure to adversity is strongly associated with substance abuse disorders. An early onset of use is associated with experiencing major traumatic events and witnessing violence. Current day unemployment is also a major concern. For those who worked full-time wages, the median yearly income was $28,919 for men and $22,834 for women, both below the median national earnings of over $37,000 and $27,000 respectively. And educational attainment varies, with 29.1% receiving less than a high school education, about 29% earning a high school diploma, another 30% completing some college, and 11% with a bachelor's degree. 65.6% of American Indian and Alaskan men participate in the labor force, which is slightly fewer than the total U.S. population of 70%. But overall, American Indians, Alaska Natives are more likely to live in poverty, over 25% of the population, as compared to the U.S. average, 12.4%. Psychological stressors may also include the following: poverty, poor housing or homelessness, lack of opportunities on the reservation compared to urban environments, neighborhood safety, parenting, and boarding schools. With regard to the boarding schools, historical genocide and the boarding school system have contributed to contemporary traumatic experience and multi-generational distress. Two-spirit individuals, gay, bisexual, or transgender, who have attended boarding schools report higher rates of alcohol use, illicit drug use, and suicidal ideations or attempts than those who had not. Further, people with a parent or caregiver who attended boarding school were significantly more likely to experience suicidal ideations, generalized anxiety disorders, or post-traumatic stress disorders than others, suggesting that boarding school attendance impacts intergenerational health. In other research with American Indian and Alaska Native individuals, even having a grandparent who attended boarding school was associated with an increased risk of suicide. Although healthcare services for American Indian and Alaska Natives are supposed to be provided by the Indian Health Service and some tribal health offices, these services are not adequate to cover the needs. Indian Health Service is the sole provider of healthcare services for about 55% of American Indians and Alaska Natives. While approximately 36% of American Indians have private health insurance and 24% rely on Medicaid, 33% have no health insurance coverage. Studies of both the urban and rural American Indian and Alaska Native populations have documented poor health, limited health care options, and limited services utilization. Barriers to services and utilization include distance to care facilities, transportation, stigma, lack of cultural sensitivity among healthcare professionals, relocation, difficulty navigating healthcare delivery systems, lack of awareness of available health resources, long waiting times for health care, difficulty adhering to medication, preference for traditional healers, and poor incentives in health promotion. Other factors also affect service delivery, such as gaps in state to tribal collaborations. American Indians and Alaska Natives are also underrepresented in the Medicaid expansion population, which affects access to and utilization of services. Now we're going to shift a little bit more to mental health and psychological distress. The American Indian Service Utilization Psychiatric Epidemiology Risk and Protective Factors Project found that the prevalence of DSM-4 disorders was 35.7% for women to nearly 50% for men. The most common disorder for women is post-traumatic stress disorder, for men, alcohol abuse and dependence. Significant levels of comorbidity were found among those with depressive and/or anxiety and substance use disorders. The National Epidemiologic Survey on Alcohol and Related Conditions also found that most American Indian and Alaska Native men, 70%, and women, almost 63%, experience at least one lifetime psychiatric disorder and were more likely to have experienced psychiatric disorders such as substance use and mood and personality disorders than their non-Hispanic white counterparts. American Indian and Alaska Natives are more likely to experience serious psychological distress in the past 30 days than their white or black counterparts. They are also 50% more likely to report hopelessness, worthlessness, and feelings of nervousness or restlessness all or most of the time as compared to their non-white Hispanic counterparts, and 80% more likely to report frequent sadness. Some researchers claim that accurate data on depression among American Indian and Alaska Native elders is challenging because most do not seek treatment for depression and are therefore potentially hidden populations and conditions. American Indian and Alaska Native youth have the highest rates of overall mental health problems compared to all other race and ethnic groups, with 30% reporting severe depression. Over 50% of American Indian and Alaska Native youth being treated for substance abuse also had untreated comorbid psychiatric disorders. Youth receiving mental health service in one urban clinic most frequently reported mood disorders, adjustment disorders, and PTSD or acute stress. American Indian and Alaska Native children experience high rates of victimization, poverty, mental disorders, and gang involvement that impact mental well-being. Conditions of poverty, loss of culture, and discrimination lead many youth to be attracted to gang activity, which is linked to higher rates of substance abuse and violence. High rates of alcohol use among youth are often linked to historical trauma and the consequences of cultural loss at many levels. Further, substance use is one of the leading factors contributing to unintentional injuries and disabilities among American Indian youth. Among American Indian and Alaska Native youth in substance abuse treatment, high rates of comorbid post-traumatic stress disorder and alcoholism, as well as history of trauma, are common. Social problems among American Indian and Alaska Native adolescents resulting from perceived discrimination and weak social ties, particularly in urban public school settings, can contribute to extreme alcohol and other drug consumption. Children who witness or experience household dysfunction, such as domestic violence, substance abuse, criminal activity, and mental illness in the home, are also more likely to report poor mental health outcomes. A higher risk for depression has been linked to how adolescents describe life events. Negative narratives about adverse life events, such as attribution of negative events to individual stupidity versus bad luck, versus positive narratives, are styles developed as early as 8th grade and underscore the need for early intervention. Researchers suggest that highly reported mental health issues in an urban clinic are linked to the pervasive effects of abuse, injustice, historical trauma, and the loss of cultural identity. As with other youth, deviant peers appear to influence delinquency and substance use behaviors among American Indian and Alaska Native youth. Youth experience more disability-based harassment and gender-based harassment compared to youth from other racial or ethnic groups. However, there are protective factors against substance use disorders and other mental health issues. Strong ethnic identity, connection to cultural values, and positive family and peer influences are protective factors among American Indian, Alaska Native youth. Suicide is one of the most serious outcomes of severe mental distress in American Indians, Alaskan Natives. In 2014, the second highest U.S. rate of suicide was among American Indian Alaska Native males. The highest rates of suicide in Native men occurred among those 15 to 24 years and 25 to 44 years. Native women between 15 to 24 years of age were almost twice as likely to complete suicide as non-Hispanic whites of the same age. Two-Spirit women who attended boarding school were 6 times more likely to report suicidal thoughts than those who did not attend boarding school, and almost 9 times more likely to attempt suicide. Among 15 to 24-year-olds, American Indian Alaska Native suicides were higher than in any other ethnic group. 16% of the Bureau of Indian Affairs high school students had attempted suicide in the past year. 64% of youth from a Southwest tribe, particularly males, were intoxicated at the time of suicide death, and 75% of those who had attempted suicide were intoxicated at that time. Alcohol is the most commonly reported source of intoxication in suicide acts, and peer pressure has also been cited as a contributing factor. Multiple risk factors put American Indian Alaska Native youth at risk for suicide ideation. In a study of youths in the Midwestern U.S., 9.5% reported suicidal thoughts. Substance use was the most strongly correlated with suicidal thoughts, but other factors included being female, perceiving discrimination, and negative life events such as family, economic, and school-related stressors. Depression and poor family social support were also associated with suicidal thoughts. Social isolation, exposure to the suicide of a friend or family member, and being overweight were associated with suicidal ideation in both American Indian, Alaska Native, and non-Hispanic whites. Turning back to adults, violence and trauma have been seen to be a major source of concern in many American Indian communities. American Indian women are more likely to be victims of violent crime than women of other ethnicities, and to develop psychiatric symptoms due to trauma and their sequelae. Sexual violence against American Indian Alaska Native women is especially deleterious. Based on the National Intimate Partner in Sexual Violence Survey in 2011, the lifetime prevalence of rape in American Indian Alaska Native is 27.5%, with another 55% reporting other forms of sexual violence. In American Indian Alaska Native women ages 15 to 35 living on or near a reservation, exposure to trauma was associated with symptoms of PTSD, substance use, and risky sexual behavior. Those with high trauma exposure who met the criteria for PTSD were at greater risk for binge drinking and risky sexual behaviors that increased their risk for HIV. There's evidence that American Indians, Alaska Natives who identify as gay, bisexual, or transgendered, also known as Two-Spirit individuals, experience disproportionately higher rates of both anti-Native and anti-gay discrimination and violence, particularly sexual violence in urban areas. Two-Spirit American Indian Alaska Native women are at a particularly high risk for substance abuse and mental health challenges, such as PTSD, due to their multiple minority oppressed status. Among Two-Spirit American Indian Alaska Native, consequences of emotional trauma have been exacerbated by boarding school attendance. Indian and Alaska Native females and males experience high rates of intimate partner violence, usually before the age of 25. Among Native women, 51.7% reported physical violence and 63.8% reported psychological aggression in intimate relationships. In a study of 18 to 45-year-old women at an IHS hospital, intimate partner violence was strongly associated with subsequent mood disorder. Although 43% of Native men reported physical violence in their relationships, reports of psychological aggression were less frequent than in most other ethnicities. Let's turn now to talk more specifically about substance use in American Indian and Alaska Native communities. American Indians, Alaska Natives have the highest rates of substance use of any racial ethnic group in the U.S., with rates of alcoholism and illicit drug use 2 to 5 times higher than the general population. Substance use is a principal causal factor in continued poor health outcomes in American Indian and Alaska Native communities. The Indian Health Services views the consequences of substance abuse as the root of the most urgent health problems in these communities. However, although substance use is a major problem facing many communities, there are major regional differences in substance abuse and related disorders between, for example, the Southwest and Great Plains communities. To understand substance abuse in both current and historical context, nuances and contextual factors influencing substance use in different populations must be accounted for. Although many cultural, social, economic, and contextual factors contribute to high rates of substance use, many strengths and sources of resiliency among American Indian and Alaska Native communities, such as strong cultural traditions, family support, and cultural pride, also contribute to abstinence and to mitigating the effects of substance abuse. American Indian and Alaska Native youth use tobacco, alcohol, and illicit substances at higher rates than adolescents of any other racial and ethnic group. Use is often initiated at younger ages compared to substance use debut in other groups. Stanley et al. Found that high prevalence rates for almost every substance, particularly marijuana, binge alcohol use, OxyContin, and this was among youth as early as 8th grade. Dixon and Johnson have found that alcohol and marijuana were the most common substances used among a cohort of American Indian and Alaska Native youth. However, youth also report relatively high rates of amphetamine and stimulant use, narcotic pain medication use, cocaine, tobacco, inhalants, hallucinogens, stimulant prescription medications, and over-the-counter medications. American Indians and Alaska Natives have the highest rates of admission for substance abuse disorders in general, and they're more likely to report alcohol as the primary substance used than any other racial or ethnic group. Mortality resulting from alcohol use is much higher among American Indians and Alaska Natives than non-American Indians and Alaska Natives, although mortality also varies considerably by region, with some of the highest rates in the northern plains and the lowest rates in the eastern United States. The prevalence of fetal alcohol syndrome is highest among American Indian and Alaska Native children as a result of higher use among women. High rates of alcohol use during pregnancy among mothers, which is 3 times the national rate, contribute to high rates of infant mortality in American Indian and Alaska Native populations. Importantly, research suggests that American Indians and Alaska Natives display higher rates of abstinence from alcohol than in the general population. However, adults who do engage in alcohol use often engage in heavier or binge use. Reservation-based populations also exhibit greater abstinence than urban populations, perhaps in part because many reservations prohibit the use and sale of alcohol within their borders. American Indian and Alaska Native people who use alcohol face an elevated risk of both mental and physical health consequences, including physical and sexual violence, accidents from intoxicated driving, and chronic health issues. There have been considerable efforts to uncover genetic predispositions to alcoholism among American Indians and Alaska Natives, but they've been unsuccessful, suggesting that social factors are largely responsible for the elevated rates. For alcohol use among American Indian Alaska Native youth, earlier studies showed that youth on average reported greater use of alcohol than did any other racial or ethnic group. However, certainly not all American Indian youth use or abuse alcohol. As noted earlier, alcohol use is extremely prevalent in communities with lifetime prevalence of 96% for men and 92% for women by the time they finish 12th grade. According to the Youth Risk Behavior Survey, American Indian and Alaska Native youth were more likely than whites to have consumed alcohol before the age of 13. Studies have found that early onset of alcohol use is predictive of multiple problems. Alcohol and drug use begins with often heavy drinking at a young age among American Indians. Individuals who initiated alcohol use before 14 were twice as likely to have substance use disorders later in life. In an urban Alaska study, alcohol dependence was associated with early onset of substance use disorder. Many were also dependent upon other substances, particularly marijuana. Binge drinking use among American Indian Alaska Native adolescents is often linked to family problems and aggressive behavior, suicide, non-suicidal self-injury, and persistent problems in later life. According to the U.S. Centers for Disease Control and Prevention, between 2005 and 2013, American Indian and Alaska Native people used tobacco at higher rates than all other U.S. populations, except individuals reporting multiple races. Smoking is also more common among males and among people living in poverty. American Indian and Alaska Native youth have the highest rates of commercial tobacco use in the United States, and early tobacco use is often associated with stress or exposure to trauma and negative peer influences. Finally, American Indian and Alaska Native smokers are consistently more likely to drink heavily than non-smokers, and although tobacco use varies considerably by region, related health consequences tend to be disproportionately higher in American Indian Alaska Native communities. High rates of tobacco use during pregnancy among American Indian and Alaska Native mothers also contribute to high rates of infant mortality in this population. Compared to other racial ethnic groups in the U.S., American Indian Alaska Natives have the highest rates of marijuana use disorders. Stanley et al. Found high prevalence rates for marijuana among American Indian and Alaska Native youth as early as 8th grade. Marijuana is reportedly the most commonly used illicit drug among youth. Beauvais found that American Indian youth appeared to have a higher sustained rate of marijuana use than the general youth population. According to the National Drug Intelligence Center, marijuana is also commonly available on reservation lands due to drug trafficking organizations in Mexico and Canada and the availability of illegal substances in major metropolitan centers. In a national survey, 13.5% of American Indian and Alaska Native 12 years of age or older reported using marijuana, compared to 10% of other racial ethnic groups, and they were half again more likely to report illicit drug use disorders. Among early admissions for substance use treatment, American Indian and Alaska Native youths were more likely than any other racial and ethnic groups to have initiated substance use by age 11 or younger, most frequently for abuse of marijuana, 63%, or alcohol, 20.8%. Early age of first use of marijuana has been associated with substance abuse, comorbid antisocial behavior, and conduct disorders. Like the trends in tobacco use, the prevalence of marijuana has decreased in recent years but still remains quite high. American Indian Alaska Native communities have high rates of use for a range of illicit substances, including stimulants, prescription medications, and increasingly methamphetamines. To generalize the trends in substance use across all American Indians and Alaska Natives would not only lead to spurious conclusions, but it would also serve to unfairly stigmatize and re-traumatize both individuals and communities. So it's important to note that patterns of substance use vary greatly among youths living in urban versus rural communities, on reservations and off-reservation lands, in tribal communities and regions, and reported rates differ significantly by population and study design. Use of opioid analgesics for non-medical reasons is higher among American Indian and Alaska Natives than among Caucasians, 6.2% versus 5.6% respectively. American Indian and Alaska Native people experience higher rates of accidental overdose as a result of opioid use, 15.7% versus 14.7%. Among American Indian and Alaska Native adolescents, past-year hospitalization or multiple arrest, as well as low family income and being treated for psychological problems, were associated with increased use of non-prescribed opioids. Another study by Stanley et al. Found a high prevalence rate for OxyContin among American Indian and Alaska Native youth as young as 8th grade. Methamphetamine use among American Indian and Alaska Natives is a serious growing concern. In a multi-ethnic national study of drug use, American Indians were 17 times as likely as blacks to have recently used methamphetamines. In a Bureau of Indian Affairs law enforcement survey, the rate of one tribe's high school seniors ever trying meth was nearly 6 times higher in 2006, just 2 years before. Compared to other racial and ethnic groups in the U.S., American Indians and Alaska Natives have the second highest methamphetamine abuse rates after Native Hawaiians. Use of methamphetamines has been increasing. Rural and reservation dwelling communities have experienced rates as high as 30%. Rural areas, including many American Indian reservations, are particularly attractive for methamphetamine production due to geographic isolation, poverty, and sparse law enforcement. Sequelae linked to meth use include increases in child abuse and neglect, violent crime, domestic violence, and dental and skin disorders. I hope this slideshow has illustrated some of the concerns around behavioral health issues for American Indian, Alaska Native youth. We want to turn now more to prevention, intervention, and treatment. Successful prevention, intervention, and treatment of behavioral health concerns in American Indian and Alaska Native populations is constrained by several barriers to service delivery. First of all, there's difficulty of diagnosing mental health conditions, lack of access to treatment services, funding limitations, and stigma towards mental health, which impose barriers to appropriate treatment and care. Despite the reported prevalence of traumatic experience among American Indian and Alaska Native individuals, few people seek treatment for trauma due to limited access to mental health services and fear of stigma and discrimination. Other known barriers to care include geography, particularly access to services located in very rural and remote locations, poverty, transportation, and an inadequate number of qualified treatment providers. In one study, Gurley et al. Found that although 75% of American Indian veterans reported a mental health or substance abuse problem, PTSD, and alcohol abuse, fewer than 20% of these veterans sought mental health care and more commonly sought care for physical health concerns. Fears of stigma and discrimination when accessing mental health services present major barriers to improving behavioral health, particularly among American Indian and Alaska Native youth. Research suggests that nearly half of American Indian and Alaska Native individuals diagnosed with mental illness seek treatment from traditional medical practitioners. Traditional medical services are often sought for the treatment of depression and anxiety. Walls, Johnson, and Whitbeck found that American Indian parents and caregivers strongly prefer traditional cultural services for mental health and substance abuse problems rather than Western behavioral health services, and they believe that these services are more effective. Increased anxiety, spiritual engagement, and past experiences with discrimination in healthcare were also associated with a preference for a traditional approach to care. To designing and implementing effective treatment programs is that Western biomedical definitions of mental health and treatment are poorly aligned with American Indian Alaskan Native understandings of wellness and healing. Divergent models of health and illness pose barriers to providing adequate and culturally resonant treatment for mental health. Many American Indian and Alaskan Native communities' understandings of mental health are incongruent with Western biomedical therapies, and attempts to treat patients from within biomedical paradigms are often perceived as colonistic or even as brainwashing by American Indian Alaska Native patients. In order to assess whether existing prevention and treatment services are effectively meeting the mental health needs of individuals suffering from mental health conditions, there has been an increasing call for integrating evidence-based practices into these services. Behind the draw of evidence-based practice has been the desire to provide all individuals with quality care that has been scientifically validated to demonstrate effectiveness. However, concerns have been raised that few studies have evaluated these programs using rigorous methods. Further, given the small size of American Indian and Alaska Native populations, these patients have been poorly represented in many studies. As a result, these studies failed to include large samples that would generate the reliability and validity characteristics of rigorous methods. Many American Indian and Alaska Native communities perceive evidence-based practice standards as incongruent with their values and a challenge to tribal sovereignty. Demonstrating the effectiveness of culturally adapted programs has been particularly challenging due to the limited representation of American Indian and Alaska Native communities in efficacy trials. In recent years, scholars have turned to culturally adapted interventions to increase the effectiveness of prevention and treatment programs in diverse populations. Culturally adapted mental health interventions tailored to a specific ethnic population are up to 4 times more effective than traditional health interventions. These interventions integrate key values, practices, and ideals within the community into the intervention design and implementation. Greiner and Smith found that interventions that use indigenous language are twice as effective as those conducted in English. Often called culturally sensitive interventions or culturally centered interventions, these programs incorporate Native values, norms, beliefs, and practices into the design, implementation, and evaluation of the intervention. The underlying premise of culturally sensitive interventions is that these methods will align with the values, beliefs, and practices and norms of the target population to increase access, promote engagement, and may be more effective. By defining health and wellness as balance within the individual and community, these interventions embrace a holistic perspective, integrating prevention and treatment strategies that promote both the individual and community well-being. Many of these programs draw upon the knowledge and expertise of community members who play a key role in designing and administering the intervention. So with all of this information in mind, let's talk a little bit more about the implications, especially for behavioral health research. Suggestions for future research to improve behavioral health among American Indians, Alaska Natives include integrating prevention and treatment services, addressing the role of stress in mental health, embracing a holistic perspective for behavioral health, integrating Western biomedical and traditional American Indian and Alaska Native healing approaches, and acknowledging the role of historical, social, and cultural inequities that contribute to poor behavioral health outcomes. While Western biomedical approaches measure the success of substance abuse prevention with outcomes such as sobriety, traditional healing focuses more on outcomes rooted in spiritual beliefs and practices, such as an individual's notion of spiritual connection and sense of belonging within the community. Researchers have found spiritual ties to traditional Native American beliefs to be particularly protective against suicide attempts. Therefore, research should be based from indigenous worldviews and perspectives using community-based participatory research approaches. Community members should be involved in the research from its conception to implementation to dissemination of results. Tribal, cultural, and linguistic diversity need to be considered throughout all phases of the research process. Culturally appropriate evaluation tools need to be validated and used to determine effectiveness of programs. Finally, we need to build capacity for community members to design and oversee research projects in their own communities. So more funding needs to be directed to train Native students and community members in behavioral health research. What are some of the implications for behavioral health services? Many would argue that to see reductions in behavioral health disparities among American Indian and Alaska Natives, there must be a genuine transformation of systems of care. System factors might include finding ways to reimburse healers for care, supporting behavioral health systems to address historical trauma and contemporary stressors, and creating alternative licensing and credentialing for American Indian and Alaska Native service providers. An example is provided by the Alaskan Native Tribal Health Consortium that has developed and implemented a behavioral health aid program. The program trains and certifies behavioral health workers to address mental health and substance abuse in Alaska Native Village and has met with very significant success. There is also a need for providers to be trained in behavioral health cultural competency to first understand their own culture and how it impacts their practice. Finally, other researchers have argued that Western therapeutic approaches are too individually focused and discredit the benefits of traditional Native healing. In addition, there are many implications for behavioral health programming. Increasingly, American Indian and Alaska Native communities are seeking culturally appropriate strategies to address the high rates of substance dependence, trauma, and violence that they're facing. The diverse worldviews of American Indian and Alaska Native communities often do not fit neatly into Western biomedical paradigms, leading to underutilization of biomedical treatment among American Indians, Alaska Natives, even in rural areas. In a review of the use of American Indian, Alaska Native traditional healing in urban communities, Hartman and Gahn reported that participation in traditional healing activities led to stronger ethnocultural identity, as well as community support, political empowerment, and resilience strategies for American Indian and Alaska Native communities. Walls, Wetback, and Armenta caution, however, that while indigenous spirituality was associated with poor psychological outcomes, the effect was attenuated by controlling for moderating factors, such as perceived discrimination and historical losses. Emphasis on American Indian, Alaska Native culture and wellness ideals is a means of preventing substance abuse in American Indian populations. Numerous treatment and prevention programs based on Native worldviews have demonstrated success, such as talking circles, family-based interventions, criminal sentences that incorporate traditional practices, and traditional ceremonies such as sweat lodge and drumming ceremonies. Strong cultural traditions, family and clan networks, cultural beliefs surrounding abstinence in American Indian communities have all been found to serve as protective and resilience-promoting factors. Prevention and treatment programs thus should emphasize family values and tribal cohesion to reduce the sense of isolation and cultural disconnection reported by many American Indian Alaskan Native drinkers. Also, research suggests that substance abuse prevention programs must target youth at early ages and account for the impacts of stress and exposure to traumatic events. Culturally relevant programs that incorporate mental health and substance abuse treatment can benefit both rural, reservation-based, and urban American Indian communities. Finally, it's important to discuss the policy implications associated with the behavioral health needs of American Indian Alaska Native communities. Behavioral health services can be accessed through a variety of sources, including private insurance, Medicaid, Indian Health Services, state and local funds, discretionary grants from state and federal resources, and tribal funds. Each of these funding options comes with its own policy implications, as each will be overseen by a variety of government groups, including local, state, tribal, and federal governing bodies. Tribal governments operate as sovereign nations and have power of authority over programs and services related to the health, safety, and welfare of their citizens, similar to state governments. It's recommended that intergovernmental agreements, including partnerships between state and tribal governments, occur when planning for resources. Ongoing collaboration between federal, tribal, and state programs with a focus on cultural practices, traditional approaches, and community healing will support sustainable policy solutions and mutual respect between partners. Tribal representatives should be involved in developing policy in the early stages of policy conceptualization, using a CBPR approach to facilitate discussions regarding policy changes can facilitate trust and also commitment to implement proposed policy reforms. Any policy-based initiatives to reform behavioral health services should include enough flexibility to provide culturally sound services. At the federal level, the Substance Abuse and Mental Health Services Administration acknowledges the importance and necessity for tribal consultation and all of their efforts to support trust, respect, and shared responsibility. In 2007, they developed a SAMHSA-specific tribal consultation policy, which outlines their consultation processes. SAMHSA also provides technical assistance resources for working with tribal groups and has several funding opportunities focused on behavioral health issues specific to American Indian Alaska Native groups. The 2010 Patient Protection and Affordable Care Act included the Indian Healthcare Improvement Reauthorization and Extension Act, in which Title VII called for a comprehensive behavioral health service initiatives in Indian country. Policies supporting the integration of primary care and behavioral health support a holistic approach to care, which aligns with traditional tribal healing practices. At the local, state, and tribal levels, there are also opportunities to reform policies to support more culturally relevant care. Policy efforts supported by local tribal groups resulted in the Arizona Medicaid program, which received approval for their Section 1115 waiver, in which Medicaid will now reimburse for tribal-based traditional healing services. Local and tribal groups can also work with Indian Health Services to establish a community health representative workforce through their local IHS offices. Community health representatives are members of local tribal communities who know the local culture, can serve as advocates, and can also provide needed culturally sound behavioral health services. While the American Indian and Alaska Native communities experience higher rates of a variety of behavioral health conditions as compared to other U.S. populations, there are opportunities through culturally relevant and collaborative research, services, programs, and policy to improve behavioral health outcomes among American Indian and Alaska Native communities. Promising approaches include a focus on Native worldviews, community assets, cultural identity, and resiliency. This concludes our presentation today. We hope that you have found it very informative and that it will inspire you to explore these issues more. I want to thank Carly Camplain, my research assistant at NAU, for helping to create this module. If you have any questions at all, please do not hesitate to contact me at julie.baldwin@nau.edu. In the meantime, I look forward to continuing to stay in close touch and wish you the very best as one of our Institute scholars.